All right, let's go back to reviewing some of these questions. As I mentioned in my other videos, these questions are written by some of our medical students, and the idea is to just to review these questions for learning's sake, and they are reflective of NBME Shelf Examination in clinical neurology. So I'm going to give you my interpretation of these questions. So 58-year-old male, he comes to the office with a complaint of prior pain in his legs. So again, this is a strange word, prior pain. Is unsure. Maybe the meaning here is there is a history of pain, but he wouldn't be presenting to you with a history of pain. Instead, he will be coming in with an actual pain. Now, they may have started years ago, but prior is an unusual word to use here. The pain was first noticed 3 months ago when the patient was pulling weeds in his yards. So onset was 3 months ago, so it's not a prior pain, it's a current pain. So it's a patient is coming in with a pain in his legs. It started 3 months ago. He's a 50-year-old male. He was working in his yard. He was pulling weeds and he noticed a pain. And he suddenly felt a back pain that seemed to spread to his leg. So that's a classic disc herniation. You're trying to lift a heavy weight. You suddenly feel a pop in your back, and then suddenly you start getting this radiating pain down to your legs, but the back pain doesn't go away. So again, more accurate start of this question should have been a 58-year-old male that comes to the office with complaint of back pain radiating to the legs, because it actually is a back pain that is going down into the legs. But let's see, maybe the back pain has now resolved. So he also noticed that he could not lift his toes afterwards and had numbness along his legs laterally below the knee and on the dorsal surface of the foot. So that's a very accurate description of the location of pain, which is numbness, which is very unusual. Patients typically don't do it, but in a STEM, we often do put information like this. So that's, if you look at your dermatome, this will be, I believe, L4 or L5, L4 or L5. So very classically over there. Now, difficulty lifting up the toes is too precise. And I'm not sure if you are having an L5 radiculopathy that will give you such a precise location of abnormality, or you could expect a foot drop, but a toe problem may not be, or maybe the description should have been he has difficulty lifting his foot, or maybe lifting his toes is lifting his foot, but may have been a little more clear exactly if they're trying to bring in a foot drop or not, which is classic for L5. When asked specifically, the patient noted that his leg pain was worse than his back pain, especially when he tried to lift his leg whilst lying in the bed. So that's a classic straight leg raising SLR test, where patient, when he's lying in the bed, raise the straight leg up, meaning no bend at the knee, and you're trying to stretch the sciatic nerve. And that sciatic nerve is L5 root, and basically stretches on the lumbar plexus and on the root, and that causes the pain because the root is pinched between the disc and the foramina and cannot move. So that ability to move back and forth, slide in and out is gone, and that certainly increases the pain and causes severe shooting pain. It's a very classic test. Normal SLR, you should, even with an old age and a lot of tightness in the muscle, you should be able to go up to 45 degrees or more, and it may be uncomfortable but shouldn't be painful. But if you're reproducing pain, not just a discomfort, at SLR, maybe even only 15, 20 degrees of raising, then that is very suggestive of a disc herniation in the back. The patient says since the incident, he has stopped doing yard work and taken ibuprofen as needed for his pain. Very classic. Upon his visit today, the patient says he no longer has any pain or symptoms from the event and is asking what may have been the cause of his pain. Okay, now it makes sense why they said prior pain. But it would be very unusual for someone to come in and say, oh, I had the pain, it gone, but now I'm here to figure out why I had it in the first place. But, maybe he's of that curious kind. So vital signs are normal. Examination shows no cervical cranial nerve deficit, normal muscle tone, strength, coordination, gait, sensory and reflex exams are now normal, which is again very unusual because the whole case is built around L5 radiculopathy. What is the most likely diagnosis? Now, so the first question is that why the authors have made the pain go away and the exam normal. Maybe they've made the pain go away because that is often the natural progression of the pain in disc herniation, that you had a herniated disc, you get a pain, and then the body adapts to it and the pain resolves. And sometimes if the pain is not improving, we often recommend physical therapy or exercises. So go do therapy, do exercise. Now the herniated disc is still there, but the nerve may start moving a little bit again. The edema goes down, the pinch gets better, and the pain improves. But often the disc is still pinching the nerve, and often if there was a loss of reflex like a foot drop or ankle, it will not improve. And often, if there is a foot drop, then it is considered surgical urgency, and you do not wait for the pain to go away. You go in and do the surgery and remove the disc because that foot drop is often permanent, once you have a foot drop. So you should have a loss of reflex and ankle, should have a foot drop, and that should not have gone away, even if the pain has gone away. And that will be a weakness of the stem. So you could make the exam normal, which is possible, but then you should not have a foot drop on the history. And this whole stem will still be fine for the intended purpose to ask for the disc herniation, even without the foot drop on history, even with normal examination, and even without resolution of pain. Or you can say the pain is resolved, and because there was no foot drop in the history, then the exam would be normal, and that would make sense. But this is classically disc herniation. So I will call it L5 disc herniation. Let's look at the other options. Epidural abscess. Why this is not epidural abscess? Because there is sudden onset in abscess. It will be gradual onset over a few days or weeks. There is no fever. There is no local tenderness. The back pain has resolved. Patient has not lost any weight. And there is no other source of infection where the epidural abscess will come from. Why is this is not a vertebral lumbar fracture? Because a vertebral fracture typically does not cause pinch herniation. There will be a lot of back pain and tenderness and difficulty in moving and mobility. There may be a straight leg raising test that's positive, but it's not a pain that starts from back that goes down to the leg. There is no, typically foot drop or things like that, unless it's a very bad compression. But then it will not be just foot drop; it will be a whole cardiac venous syndrome or something worse than that. Metastatic cancer to the lumbar spine is possible. Sudden onset is possible if the disc bulge is actually related to the metastatic cancer, or if there was a sudden crash of the vertebra. So metastatic cancer is not completely ruled out, but there is nothing in the stem. In real life, it's not ruled out. But here in the stem, there is nothing that is being given to you to say this is metastatic cancer. There's no weight loss. There is no bowel abnormalities. There is no chills and rigors and so on and so forth, whatever you expect from a cancer. And there's no information about a primary, where this may be coming from, or difficulty passing urine from a prostate cancer, and so on and so forth. So that's why in this stem, this is not, you wouldn't worry about metastatic cancer, but in real life you would still, unless you've asked those questions and those questions are negative. So here, of course, L5 disc herniation makes more sense out of all the question information given. And let's see if I'm right. And I am right. All right, let's stop here and we'll do another question later.